First of all, maybe I should just explain. You might wonder, do they want us to show you all the different rooms at UBC? Peter Wall proactively has encouraged the first 2 days to be fairly focused, and we're now beginning to merge out to provide an opportunity to the broader UBC community. And there are some extra people here who aren't here. And as the day progresses, there are up to 40 or 50 people in total, ourselves included, may come depending on the enthusiasm on this nice sunny day. When they accepted invites a few weeks ago when it was raining, it probably was more appealing. But anyway, so just to give you the conceptual idea, the idea here, and the idea we're here now and we'll move to the bigger room afterwards in the next session, is that it's an opportunity for people within UBC health literacy community to join us. And Peter Wall, in terms of structuring it, has decided that these preliminary days should be a chance for us who have expertise, or like me, a wannabe expertise in health literacy, can come together, and then it'll stretch out. So there is some method in the madness of all of this moving around. So I just want to give you some context for that. And I also want to acknowledge our appreciation for Peter Wall in terms of giving us direction. So the session we're about to have now will involve the cabinet here, the front bench as it were, giving some reflections on the theme that Sandy, and basically how we're going to run it is that I'll just pick people, maybe starting with Rima, just to speak for 3 or 4 minutes, just reflecting on the topic in terms of chronic disease management, health literacy, and we'll then open it up for discussion. So we have co-opted Connie Davies, and so we've got 7 people. So we're going, hopefully people will speak for about 4 or 5 minutes, and then we will have a sort of very much a roundtable discussion. I don't know whether this is a very nice room, but if you ever get an opportunity to go to this, I would call this the mini WASC. There's a WASC room downtown in Vancouver, which is seats about 120 or 30 people, but it's a totally in the round room, and it's quite spectacular. So this is a mini WASC. So I'll ask maybe Rima to give us some reflections. Thank you, Rima.
Okay.
And yeah.
Well, I want to make note of our foundation, and our foundation for all of the work that we do and what we're now calling health literacy studies really comes from education. And so in setting that foundation, I think it's very important that we pay attention to the fact that literacy is very often socially determined. And so we can predict in almost any population group or in any society who will and who will likely not have good literacy skills, depending upon a variety of social factors. Scholarship in education has also shown us that literacy becomes a social determinant in and of itself for any number of factors, including health. So this foundation is set for us. Now let's take a step on that foundation and see where it's built even further. So we know from scholars like Paulo Freire, we know from scholars like Victoria Purcell-Gates, that literacy is very clearly linked to issues of social justice, because literacy is very dependent upon context and the dialogue and discussions that take place within that context. And that can be done with dignity or not. And it's very important to pay attention to the need for dignity and agency in all of those discussions, whether there is a match between speaker and listener or not. There still must be that preemptive call for dignified and respectful interaction that really leads to agency. And I think that seeps through and should seep through all of our work. So when health practitioners and health researchers first paid attention to literacy, really as a group, starting in the late 1990s, there was attention being paid, and the call to action really came from the question, the research question, are there links between literacy skills and health outcomes? The answer, of course, was yes. But many of the health practitioners only looked at one side of the coin. They dissected the patient and the patient's deficits and the patient's literacy skills. They forgot, in many instances, to look in the mirror and say, how am I talking and writing, and what are the circumstances that I'm creating within which I expect people to function? So only recently have people begun to look in the mirror at themselves, But more than that, because it's not just self-blame amongst us professionals, but to look at the structure and the context that we've helped create and we've helped maintain, and see ways in which that structure erects barriers so that information is not accessible, so that dialogue is not possible, so that action is hindered by cumbersome tools and inappropriate instructions and discussions that do and do not take place. So there are insights to draw from health literacy studies, which has established a link between literacy and health outcomes, but it's really not the patient's literacy skills that determines the health outcomes. It's the larger context, and it's the mismatch that is going on that really leads to poor health outcomes. And so in order to make change, we have to change that context, and we have to be involved in multiple ways. Now, for chronic disease management, I think that we need first a level of self-analysis, where we look very closely at what we do, at what we offer, at what we prepare for others, and the tools that we offer others, and say to ourselves, how can barriers be eliminated, literacy-related barriers be eliminated? That's only one step. It's a preliminary step. But that analysis then requires us to understand what the literacy demands are, what the assumptions are, what the untoward expectations are, and then we can start making corrections. As we make those corrections, it would serve us well if we do it in a rigorous way, so that if we clearly define what we're doing, what we're changing, and we observe with careful rigor as scholars, and make sure that we launch research efforts to be able to say that we can reach a gold standard because X works and Y doesn't under certain circumstances, in combination with other factors. So I think that it's time now for us to proceed with research implementation studies, but to make sure that we do that with due diligence and with rigor. And we really follow really good research protocols. So that's my opener, I guess.
Wonderful, thank you. I think next is Scott. Scott, do you want to reflect a little?
Sure. Thanks, Mark. I agree with Rima on all sorts of things, but come from it at a quite different way. Where we've been spending our time is using economics to define the incentives that people have to acquire the skills we're talking about in the first place, and then to apply them and in fact keep them over the life course. So lots of time on the performance of education systems in creating skill, and in the labor market rewarding them or not. And what we find is huge skill loss that was unexpected because we have a lot of dumb jobs, and if you translate that into the health system compensates a lot for people with low skills, so ironically removes much of the incentive for people to acquire health literacy skills and then to apply them. We're also spending a lot of time on the demand for literacy skills generally and health literacy, and how technology is changing those demands, and on the markets that mediate skill and supply and demand. That happens in the labor market, but it also happens in the healthcare system. And our overriding analysis is that there are market failures, and that individuals and institutions and governments are failing to invest optimally. And that's costing us an enormous amount in terms of lost productivity, and in much higher costs for educating and for delivering health goods and services and many other public services. Part of it is a very nasty, cynical thing about institutions seeking rents, which is exactly what economic theory would suggest. You're trying to maximize your benefit at the expense of others. And so some of it's that, but some of it is just inertia in a very large system that lacks the proper sort of incentives. So our way of dealing with this, there's two ways of dealing with it: run away into the countryside and live without electricity, or deal with it pragmatically as a political problem to be dealt with. So what we're doing, because I'll use it as a Scott's answer to these problems, We have built web-based literacy and health literacy tests for multiple purposes with a very large amount of government money. They were designed to be valid and reliable, but they were also designed to be cheap enough and compact enough that they would not get in the way of the other things that the system has to do. So we have things for use in everything from triage into programs to use in very high, I'd say high-gain clinical settings, clinical studies. The second thing we've been doing is running very large-scale national intervention studies to prove that we could change the status quo by delivering focused, high-quality instruction and seeing what happens when you actually give people those skills. And the early results are dramatic, not just for the individual, but for the institutions in which they sit. And it isn't just the health system. We're working with 2-level randomized controlled trials, which are devilishly complicated to run, but showing huge impacts on work groups within firms and on the profitability of the firms that we're touching. In stupid places like 120 hotels across the country with cleaners. So if you're getting big wage and productivity returns in such places, imagine what might happen in the education system or the health system. And then the last thing that we're doing is running a series of cost-benefit analyses and rates of return, even though if you look at even the simple data, things are self-evident that this makes sense to invest in. Governments are reluctant to poke the big beasts of systems, you know, poking the K-12 system or the college system or the health system is dangerous business for a bureaucrat. So we're trying to give them hope and courage by showing them just how big the rates of return might be. And those rates of return, even without the health care, 5-year fiscal rates of return are close to 1,500%. And that makes it for governments almost irresistible. And then the last bit we're doing, no, it's not, there's 2 last bits. If you assume that governments and institutions and individuals will invest, the problem is that the carrying capacity of the system isn't there. Depending on the program you stumble into, you could get very high quality or very low quality. So we're in the process of building a national delivery network that is committed to quality, demonstrates quality, and has got things like credentials for learners, credentials for instructors, credentials, accreditation for programs, so that if anybody gets brave enough to stumble into a program, they're going to get what they paid for, either with their time or their money. And then the last bit is, even with all of that, if Scott assumes that those pieces all get put in place, we need some randomized controlled trials that are big enough to show unequivocally the directions of causality, because the people who are in decision-making positions simply don't get it and won't accept it, even if the case is made quite subtly and with lots of evidence. So we're running one of those in the education system with most of the colleges in the country. I have to set this up. 60% of the kids in college programs in Canada have level 1 and 2 skills, which means they don't have the cognitive carrying capacity to get much, if anything, out of that experience. 11% of the university students in Canada are at level 1 and 2. So institutions are taking their money, giving them something. The ones that don't like that very much end up dropping out, so there's a huge productivity problem in the education system. Then you get to the healthcare system and you have the same phenomena, but with a little different twist, that the system is carrying enough, it starts to compensate. And in compensating, it diminishes the power of the individual and enriches itself. And in economic theory, this is just a little more rent-seeking on the part of the institutions. So an argument for fairly rigorous and focused research showing that you can change the world. Thanks.
Thanks very much. I think it's the first time in a while I've been at a meeting where somebody's going to change the world. So I'm glad you're. No, I think I don't want to be facetious. I think that's very impressive. So we'll move on to ask Nancy to give some reflection. Well, I should have mentioned that most of us know each other, but I should have actually prefaced by saying that there are some new people, so maybe when you introduce yourself, just to let us know your affiliations, maybe in a brief 10, 15 second thumbnail sketch of your life now. Just a general idea.
Is this on? Okay, thanks. I'm Nancy Brookman, and I work at RTI International, which is a research firm in North Carolina. Yesterday I talked about a health literacy skills instrument that I developed, and today I just want to talk a little bit about other work that I've done in health literacy, which is, I'm the guy who does the systematic reviews on health literacy. I've done two, and the focus of those reviews have been on the relationship between health literacy and health outcomes, and the other one is on intervention, so we've covered both of those topics. And I've done this twice, so we did the last one in 2011. And there's a lot of literature out there on health literacy in terms of the relationship between health literacy and outcomes, measured primarily as reading skills. The instruments are primarily about reading. There's a little bit about numeracy, and as we've been saying, I think that the relationship has been firmly established. I mean, we saw strong evidence of associations between health literacy, low health literacy, and more hospitalizations, greater use of emergency care, lower receipt of mammography, influenza vaccine, poor ability to demonstrate taking medications, poor ability to interpret labels, health messages. And the other thing that we saw really strongly was a relationship among seniors with a higher mortality in some very large, well-designed studies. And so in a lot of areas we think that it's been established, less has been established in terms of numeracy. So it's sort of out there. It doesn't address the question, so then what do we do? And the literature about that in terms of how do you sort of translate research into practice, there are fewer trials. I mean, we found that there were about 38 trials to look at in terms of interventions where they specifically evaluated the health literacy of the participants in the trial. So we've talked a lot about, there's a lot of aspects of how to communicate to patients and what needs to be done and whose role and whatever, but this was this one slice where the studies were looking at, to some extent, looking at health literacy, and there's less out there in terms of the advice from those studies, and I think there's a lot more research that needs to be done. Things like multiple discrete design features and improved comprehension, intensive self-management interventions, using arrays, sort of more clearly stating the information, always having sort of the higher number is better, adding icon arrays to numerical information, adding video to verbal narratives. I mean, these seem to be very sort of concrete, simple things, and I think you can look to the trials to give, if you're trying to practice and implement some things, look to them for that advice. So I think there's a lot more work that needs to be done. I think Scott is doing some really excellent work in terms of more global things. I guess this is just, I also want to take sort of a moment, sort of as an advertisement for these studies. I mean, if you want to know where the research is at and what's been done, these systematic reviews that get published as journal articles is a nice way to sort of review things pretty quickly. There's some other reviews that have been done. One has been done, I think, recently on health communication, and I know another one has been done in terms of medication adherence. And you can look to those reviews to get ideas about how to deal with a lower health literacy population as well.
Thanks very much. I've read your annals one. Where is the intervention one published?
Journal of Health Communications.
Okay, very good. But the annals one is a beautiful one. So thank you for that, Nancy. So we'll switch to Andrew.
My name is Andrew Pleasant. I work at a very small public charity nonprofit located in Tucson, Arizona called the Canyon Ranch Institute. Health literacy is a primary focus of what we do with the goals of preventing chronic disease, an issue which has probably not been addressed as much over the last 2 days as one would hope, because we've gone to management, which almost gives up the notion that prevention is possible. And I would argue that's absolutely untrue and an unproductive way to look at this. In terms of health literacy, I think it's one of the most powerful tools that we have. I guess there's still an open question on whether it's just literacy in a healthcare context, or if you introduce the healthcare context, it becomes more than simply reading, writing, and numeracy. And I don't think people have actually agreed on that, unfortunately. In my view, it is fundamentally different. If it's just literacy, then we really don't need the phrase health literacy. If that's true, it's either redundant or meaningless. Then it's just literacy in a healthcare context, and if that's what it is, that's what we should call it. That's not my view, but I think we need to just be upfront and direct about that. I guess what we haven't also talked about a lot is people. And if you have the privilege like I do of going into communities, low income, suffering inequities in health and well-being in a variety of ways, and you meet people who, quote unquote, have low health literacy, you find out that they're living lives in a context most of us would find impossible. And I think that's really important to remember in your studies, your research, your writing, your practice. And it really argues against following what is in research the dominant mode of reductionism and looking at the smallest possible unit. If you want to make a difference in people's lives in the world, you have to address the whole person. You can't just do what medicine has done for years and treat a disease and ignore the person. And I would really hate for health literacy to end up becoming subject to that worldview. It's the whole idea is to change that worldview, not live within it. So when we design our tools, when we design our interventions, we need to take a very broad and integrative approach, and that means it's complex and it's messy, and sometimes it's too expensive, and sometimes you find out that you can absolutely change somebody's life. I met a man in the South Bronx, which is the poorest congressional district in the United States, ironically enough. It's not on a reservation. It's about a mile from Manhattan. And Montserrat came into one of our programs, overweight, had isolated himself from life and given up on his dream to become a teacher. So in 12 weeks, he lost 53 pounds, pulled himself back off insulin management and turned into lifestyle management. And now, 3 years later, he is almost finishing up his master's degree in education and teaching children again. That's the power of health literacy. And I don't think it's captured in numbers or the realm of the TOEFL that are inconsistently and poorly used and methodologically weak, but they're the basis for the field. And that's, I think, what we need to change. That's about my 2.5 minutes worth. Thanks.
Thanks very much. I'll just take that back for...
Yep.
Thank you. We tried to silence you, Andrew, but we were obviously unsuccessful. So
keep at it.
No, your words are too full of too much wisdom to be silenced. Thank you for that those thoughts, and very important thoughts. So we switch to Sterling.
Great, thanks. That's a powerful story. I didn't have a powerful story like that, but so I'm going to start off by telling you about my ignorance about health literacy. So this isn't a topic that I have thought very much about. And so what am I doing on the panel is a question I have for you. I tell my kids that it's important to be outside of your comfort zone if you're going to grow and learn. So I'm taking some of my own medicine by being here this morning. But naivety to the topic, I think, can sometimes hopefully bring insights, because people don't necessarily, having someone step back and look at a subject and a topic can sometimes bring insights. It can also just bring dumb questions. So you've got to tell me whether I'm providing any insights or whether I'm just asking dumb questions. Okay, so I'm an economist, and so the lens I bring to health literacy is, I guess, the same as Scott's in many respects. I'm very impressed by the work that Scott's doing, and I see great value, and I hope that we can build some collaboration as a result of this workshop. I think that would be great. The lens that an economist brings is scarcity. So that's the overarching idea that economics has. So it's not a very profound discipline. All we do is say that we have limited resource, as if you didn't know that. and we have to try and get best value. So it's the value proposition, the value concept that the economist is trying to think about. So in terms of thinking about health literacy, I'm quite intrigued by, so how does this fit with my worldview and my work? And I'm thinking of health literacy as a facilitator to value. So I've got like one sort of thing where I'm thinking this is something that's important in the concept of actually facilitating value, actually bringing value, and I'll speak a bit more to that. And then my second is health literacy as a value proposition in its own right. So let me talk about those two things. So as a value facilitator and as a value proposition in its own right. So the value facilitator, I think that part of the conversation that I've heard that falls under that header is to do with healthcare interventions. So health literacy and improving health literacy might be a way for us to get better value out of what we're currently doing in healthcare. So in terms of the investments we're making, the technologies we're using, the therapies, the services that we're providing, we may get better value if we've got improvements in health literacy. And so there's an efficiency gain potentially that we could have in terms of what we're currently doing. And I guess that takes you down a road of thinking about adherence. It talks about compliance, in inverted commas, to therapy, so that we are getting value. And I think there's an important sort of agenda there, but that's clearly not the only agenda. So I think literacy as health literacy, not literacy, health literacy, I think I agree with you, as a facilitator to getting value. But then the other thing I really sort of heard quite a strong message about, I think, is that health literacy can be a value proposition in its own right, because we're wanting then to use this as a vehicle to provide people with the opportunity to engage in self-management, for people to view themselves as producers of health, and not be consumers, and I think that was an important message. The word consumer gives the wrong impression, and I think a consumer is language that economists are guilty of probably using and overusing in a health context, and bring about empowerment for patients so that they then see themselves as the routes through which health can be achieved. So that, for me, is then health literacy as a value proposition in its own right. And I think sort of thinking about those two things, I think as sort of obviously interrelated, but conceptually distinct routes through which we can talk about value and value gains as a result of health literacy improvements, I think for me that's a frame in which I'm sort of thinking about this. And then as a sort of an adjunct sort of thought I had just this morning was, I mean, often economists talk about agency in healthcare, and I'm quite interested in that agency relationship in healthcare, and we look to try and, we worry about agency, and agency in terms of I almost said consumer, the patient or the person who's receiving healthcare not being informed and not able to make an informed judgment about how they should behave or what they should receive in terms of healthcare interventions. And so the physician or the healthcare professional acts as an agent, and we worry about how do we have the most efficient agency relationship in healthcare, where we have this limited knowledge on the part of the consumer, in inverted commas. And so we think about things like supplier-induced demand, and we worry about people taking advantage, so physicians taking advantage of the poor, innocent, ill-informed person who's consuming healthcare. So health literacy, I think then, a lens of health literacy in terms of how we can bring about improvement in the agency relationship, as an economist would refer to it, I think is also an important thing that we should be thinking about, that's distinct from health literacy as a facilitator to value and health literacy as a value proposition. I think that health literacy lens on the agency relationship and how we can improve agency in healthcare, which takes us down the road of shared decision making and these sorts of ideas, I think, and how we can actually improve that is another lens. So I'm just like setting out like my sort of rather random thoughts on how an economist might think about health literacy, but that's where I'm at.
I wouldn't say they were random at all. There's a nice logic to them. So thank you, Sterling. Connie, maybe we'll ask you to give your reflections.
Well, I had to do visuals, so my apologies. So I guess Irv asked me, I guess I can use this slide. Irv asked me yesterday just to tell you a little bit about an experience we had that just kind of is a practical example of what is currently happening or recently happened, trying to bring health literacy together in the community. And so I want to tell you a little bit about health literacy and communities prototype collaborative that we did here in British Columbia, but just first a reminder that jargon is everywhere. This is courtesy of my son-in-law. I have no idea what he's talking about on this account. And so this was a rather large effort, and so Irving Rootman and Marina Nix were in the room, was involved in this. And what we did is we brought together literacy programs in communities with primary care practices. So the people you see in this picture were the people who participated. They were in 4 communities across British Columbia. They were served, and one practice had over 11 languages that was spoken amongst the members of the practice team, so a very diverse community. We had a First Nations, very rural, remote community. We had urban communities, so it was a very broad group of people. And we had literacy learners working with us alongside from the very beginning, from the first meeting, which Iraj attended and helped us out. So our premise was that if we bring the literacy programs and the healthcare professionals together, that we could do some good based on what the current evidence was. And one of the things that you do, this is a quality improvement effort. So some of the things that you do is you try to bring together what's known from the science, along with some methods of measurement that aren't as rigorous as research methods, but can be useful to help you know about whether or not what you're doing is making a difference. And so what we did is we put together the evidence into, in the quality improvement jargon, is called a change package. So we just took what was known about what might work and put it together in a way that we thought the teams made up from these 2 different groups could take action on it. And it turned out that with the help of Joanne Prothero, we realized that we could conceptualize it as an umbrella. That health literacy is like an umbrella that can protect people from health problems and risks that might rain down on them. And the 3 different ideas for change fell into 3 different buckets. And they're represented by the different colors of the spokes of the umbrella. A lot of it's about relationships, and it's about how you respect people and their values and preferences and bring that into account in the relationship. And then a lot of health literacy, currently the focus is on understanding, which is a big part of it. So we help the teams learn more about plain language, plain speech, about how to do follow-up in the healthcare setting, and help the literacy learners understand how important follow-up was from their point of view. How you use technology, and a lot about wayfinding. The literacy learners did amazing things like they help the healthcare professionals see that when I go to visit your office, I get off the elevator and there's no sign that tells me where your office is. I mean, simple stuff like that that were just so apparent when you have that partnership in gear. And the last part was actually about partnering across all the different people that really care about this issue. So the community-based organizations, the nonprofits, et cetera. So thinking about peer support opportunities, resources, and opportunities for improving education all around. So this is a snapshot of what we use to help the teams test and try changes in their practice. And what I'm going to show you right now is one of the practices, their data. So we collect data both in the literacy programs and in the practices. And so what I'm going to show you is just some of the data. These are the kinds of things we taught people, by the way, and what they did. Helped patients, the literacy learners, set the agenda for the visit. They did a nice program to orient providers to working in their unique community. And that literacy program is set in a return to work program too. So lots of wonderful things happening. Of course, we use TeachBack. We talked about plain language, and we did the health literacy walkthroughs. This is Dr. James He's data, and he gave us permission to share his data. It's a little old right now because this effort happened a few years ago. But I just want you to see what Dr. He learned. Dr. He's data on the first graph is the brown data, and the yellow is all other primary care doctors in British Columbia. And this is their rate of testing people for their cholesterol, people who have diabetes. And you can see that Dr. He already was much better than most of his peers in doing this. He'd been working on chronic disease management and chronic disease improvement, but he had plateaued. He started working on health literacy using teach back in his practice, asking his people if they understood, and you can see what happened to his findings. He was actually able to increase his rates of LDL cholesterol testing, a process measure. Just something on the road that might help you think change might be happening. The second graph is about the percent of observations which were reaching the outcome that he wanted. So again, this is a proxy measure, not really the outcome we want, which is decreased heart attacks and strokes and things like that, but it's one of the best measures we can do in an office practice setting. So you can see once again, Dr. He started out above his peers, but he did make improvements even above and beyond that when he started to improve health literacy in his practice. So that's the story that I just wanted to share with you, just a little bit about real practical things that can happen when you bring all the folks together that have some interest in this particular issue. What's happened since that time is the practice support program of the BC Medical Association has understood that health literacy is really important for their members to understand. It is now incorporated into their process improvements around folding group medical visits and around self-management support. So it's totally incorporated into that method, into every project that they do from here on.
Thanks very much, Connie. So we leave the godfather. What you say? Final word.
Yeah, it's both a blessing and a curse to be the last person. Being the last person may leave you with nothing to say, or may leave you with too much to mop up, but I'm not sure. Anyways, I just want to start by commenting on who's sitting around the table. We have a physician, we have two economists. I'm not sure why we need two of those. But we got
Most people think you don't need any.
Somebody from education.
They have to check each other all the time.
We've got a nurse practitioner, and we've got a policy person and a sociologist sitting around the table. And
Who's the educator?
Aren't you an educator?
Public health practitioner.
Health practitioner.
And
Well,
researcher.
we've got educators up there, so anyways, you should be down there and read. But I think the point that I'm trying to make is that health literacy has been a way of making bridges between different kinds of professional groups. And I use that metaphor here in this book that was recently released out of a conference in England. And Rima has a chapter in here, and I wrote the preface to the book. And I use that metaphor of health literacy being like a bridge, because it does bridge within the health sector, and it bridges outside the health sector. And I know that what we were asked to do here was to talk about the bridge between health literacy and chronic disease management. And I noticed also that I don't think anybody really took the assignment seriously, but actually talked about things that were around that assignment and that are really important in terms of understanding what it is that we're doing here and what literacy is. So in the couple of minutes that I have left, I just want to comment on some of the things that were said. I spent most of my career as a researcher and a research manager in government and outside government, and so I know research. And yesterday I mentioned participatory research, and some of you may think that I was saying that we don't need to be rigorous in our research, but I wasn't saying that at all. And I endorse what a number of people around this table have said about being rigorous. And you can be rigorous in participatory research, you can be rigorous in qualitative research. Of course, we expect people to be rigorous in quantitative research. And you can be rigorous in the kind of research that we just saw up there, which was kind of on the fly on the side of the table. But I think Dr. He actually, in a way, knew what he was doing, because he had that baseline of doctors in BC. Now, it's not the definitive study, but it helps us move along the way. I also want to say something about the issue of definition of health literacy. I know that we have no total agreement on on the definition of health literacy, but it seems to me that over the past couple of years, we've actually made a fair amount of progress in developing some kind of a consensus among people working in the field. And I think it's reflected in part in this book that came out of the conference in the UK. I think it's reflected in Andrew's article that came out about the same time in the Journal of Health Communication, and in many other places. So we really have made a lot of progress in the last couple of years in this in terms of definition. And for me, what really helps is achieving some kind of consensus on the key elements of health literacy. And I think there is a growing consensus that it has something to do with accessing information, something to do with understanding information, something to do with evaluating information, and something to do with communicating information, and maybe something to do with using information. I think more and more people are using that as a bit of a framework for health literacy, but they're also starting to realize that you can't just look at it from the point of view of the individual, the person, the lay person, who's got a lot of other worries besides health literacy. You have to also consider the role that professionals play and the role that the system plays. And I think we've heard a lot of that in this meeting up to this point. And so health literacy, it's important to look at health literacy at all those levels. And in terms of measurement, we need, I think we've also agreed that we may not need as a chronic disease management specific measure of health literacy, but we possibly could use a chronic disease specific measure of the professional skills and professional practices in this area, as well as system practices in this area. So maybe the place to be looking at developing new measures is there rather than at the individual level. And that's a big challenge, but given the brains that are around the table and around this circle up here, I'm sure we can address it.
Thanks very much, Eric. Well, I must say, I thought those comments were integrative, supportive, and very reflective. You know, I just thought they all had a different message. But you know, what Andrew's story sort of resonated with me, because I think if you treat people with dignity and are respectful in the broad sense, then health literacy will take care of itself. And I think that's a huge challenge in the healthcare industry, for want of a term. And it really is, you know, I work in an acute care setting, and you try to integrate those concepts, but you work in a chaotic, running at 95% capacity, which is not the appropriate capacity for a healthcare delivery model. You should be running about 85%. So everybody's looking to move somebody out. You've got somebody chasing you to who you're discharging today. And you've somebody in the emergency room saying, when are you going to admit this patient? And, you know, I'm very much into quality improvement and quality in that. And, you know, all this dates back to Toyota and that. But when that car goes down the assembly line, it's going down on a straight assembly line with 200 predetermined or 5,000 predetermined parts that have to be put in place. And I think part of the challenge we face is we work, certainly in the acute care side, when you move into community, it's a little less chaotic and more controlled. You deal with very challenging situations. And I think that's another aspect of health literacy, that you may aspire to achieve a lot of the principles we've discussed around the table, but sometimes the system gets in the way because it's quite a challenging system to work in. So I'd like to throw the discussion open to the broader community. Marina is going to start.
Very, very useful. Thank you, everyone. Because I've been thinking about health literacy and doing work for a while, but I've had some insights. Even looking back at the work that we did, I was thinking, oh, that's something different that I was able to understand differently because of some of the things that you said to me. So I felt uncomfortable with some of the aspects of health literacy and how the research had been going specifically to the measurement of individuals' health literacy before and after interventions. And some of that was reflected in what Rootman was saying. But Andrew's question about what is, you know, are we thinking about health literacy as literacy in the context of, say, healthcare, I would say health, rather broadly, or is it something different? And you say it's something different. I'm going, no, it's not. Well, let's let myself go there. And I'm thinking, is it that when we're thinking about health literacy, rather than separate it, it's the fit, and I'm maybe saying the same thing that you have been saying all along, but it's the alignment of the skills of these three different groups. It's the individuals and the system and the providers. And if we think that that any intervention result that we're going to be measuring is in the individual's ability, we're fooling ourselves, because that's not what the health professionals are doing. And he saw it, like that's what I was saying, oh, look at that. What Dr. He did is he changed his own strategies. And the results were there. He didn't measure people before and after, he just assumed. And truly, he was asking, how would you like to get the information? Is the best way that you receive information? And then we saw the differences. So I wonder if when we're looking at health literacy, the definition, and we're talking about, the four components, but truly, the difference that we're talking, what we're saying is health literacy, acknowledging that what we know about literacy and education, how socially constructed it is. But what we're talking about is that congruence or lack of congruence. And where we, health literacy need to put the effort, the focus on, is on those changes that being in the health field, in the health field, really can influence or impact more. The only worry that I have is that coming from a very underfunded field, as is adult literacy, talking about health literacy in a different way allowed us to have a say in it. And I don't want to let go of that, because of the changes and the way, it was very clear in the prototype that there was a say, that the insights that people in the education, and particularly the adult literacy field, could bring were really informative and helped make any changes in the other legs of this three-legged stool.
Thank you. Any other?
I've heard several times and appreciate this idea that we're looking at alignment between individuals, the system, and providers. But I think we're missing a piece. So we talk about providers in their context, which is the system. We need to include the individual's context, which is the social part. We cannot take that individual out of their whole life and only look at them as a patient.
Actually, I'll give Jim, because he's on the...
No, I think one response.
You want to
just use much of them. If people want to respond to that first, and then I have a question.
Go ahead.
I just wanted to reinforce what Marina said. It's about a power imbalance. I want people to have skills so that they don't have to be subject to the whim of a health practitioner being interested. If you redress that power balance, it becomes quite a different conversation. If you don't, then you risk these power imbalances. And if you come back to the economics, believing that the providers, be they educational or health or any other social service, aren't trying to maximize their rents, you're being Pollyanna.
And the other, sorry, Nancy, you want to come?
I just want to make a point. I think that was a really excellent point, because I think one of the things we haven't talked about is proxies, or that people actually bring to their appointments in terms of caring for themselves like their family members. And particularly someone who has a chronic disease, they're going to, probably the family's going to be involved, and there's the knowledge that they get from the family members or share, it goes back and forth. And I think that's a really important point. We need to think about that too. It's just not the health literacy of the individual, it's the health literacy of the individual and their community, their support system.
Sometimes described as collective.
The collective literacy. Right. Collective you, yeah.
I think Iraj spoke to this yesterday, certainly in the work we've done, is that the champion, the domestic champion, and the sort of navigator is very important. So if we've had conclusion on that point, I'll pass it over to Jim.
I have a question. Recognizing that we're here to talk about chronic disease prevention and treatment and things. And we can't not do health literacy with our patients and other things. We have to do it. Many good reasons for doing it. My question is, what do you think of the pros and cons of trying to change health literacy in society one person at a time? It seems like a losing proposition, that we're going to make meaningful dent in health literacy, one patient or one client or whatever we call them at a time.
Go ahead.
I also just wanted to remind you of the work of Don Nupping. It's not just skills, there's also the structural level that we need to talk about, and whether or not there's those other support systems in place so that people can have different support systems, just what Jim is talking about, that will enable them to take action. So if there's certain power dynamics, for example, that might constrain their ability to manage their chronic disease in their own social environment, that there's structural systems in place that support those people.
So, just go ahead.
Sorry. Is this automatically on?
If you press.
Push.
Yeah.
Now it's on. Okay. Thank you. I wanted to pick up on 2 points. One of them is what Jim just said. I don't think that there is necessarily a choice here, Jim. I think that there are people who are going to continue to work with individuals who need interventions, right? And there isn't a... Yeah, okay, right. I don't think that, yes, it would take an awfully long time to change the world if that were the only approach you had. I mean, I think one of the reasons for thinking about the system and the people who are providing the service, for years and years and years, I've worked in faculty development when I worked strictly in education. And my sense was that every time a teacher made a change in his or her practice, they were going to touch every student who passed through their classroom, every student that they came into contact with for the rest of their lives. And so the multiplier effect is enormous. So every time we engage a healthcare provider to think about the practices they're engaging in, they're going to touch every single individual. And I take your point about the chaotic system and the stresses. And I've been inside and see a priority. Clearly, we can have a health literacy project, but if there's somebody dying at the door, somebody's not going to stop and engage in the piece of research we're doing or the project we're doing. They're going to attend to the person who needs their help. But having said that, there are also, in the education system, teachers will say, everything is so overwhelming and we're asked to do everything and we have no space or time to add one more thing to our load. And sometimes, the place we start is say, can we look at the system that's there and just identify some places where there are a few little spaces and use those little spaces as wedges and begin to make whatever changes we can to support whatever it is you want to happen. And it's sometimes amazing. I mean, I think this is where you go back to the attributes of a health literate organization. So I think we need to be working on all the fronts, not on one. We need to be working on all the fronts and assume that each time we do it, you're going to get, there are some, in some respects, I do buy the economic return. In some respects, there are certain kinds of interventions that are going to give you a much bigger return. And I do think that the systemic ones are the ones that are likely to do it, and then the provider ones are going to do it even more, and then you keep working with the individuals, because then you have the stories that Andrew told. I mean, I guess the discipline that you're missing, Irv. I mean, I come out of a completely different humanities literature discipline, and I'm quite interested in the amount of talk I've heard about narrative and story, because we hear that repeatedly. And there's a whole strand of medical practice today around narratology, and not just using story to communicate with clients and patients, but listening to their stories, because when you're able to listen to stories and pull threads out of a narrative, can actually help with diagnosis. So I think there are many ways that we can draw on interdisciplinary strands and all of those fronts.
Thank you, Irving.
Great, thank you. This notion of one person at a time, I think, also comes out of the fact that we spend a lot of our time talking about health literacy insights as accrued in medical practice, because that's where a lot of the work, almost all of the work, has been done. So if we move beyond the individual, we're moving into public health. We're moving into the public discourse, and I think we have to change the public discourse. So this involves journalists to make information more accessible to people. Most of us in health, in public health, in mental health, spend a lot of our time as academics, certainly, making sure that we get journal articles published. You know, we're not speaking the everyday language of the public. We need to become bilingual. We need to be bilingual, whatever our discipline might be, so that we're speaking the educated language of our discipline, but we're also familiar with speaking in the marketplace of everyday ideas. And we're engaging people yet again. We're engaging the public. And I think that we can do that only if we make changes in our own discourse style. So we have to begin to drop our jargon. We have to begin to engage more in community. We have to begin more in engaging in participatory work, not just participatory research, which is very important because people need to be engaged in making meaning. But participatory program design, participatory evaluation, participatory assessments of materials, using people's own words and not our words as we communicate important information. So, you know, quite frankly, I'm a little nervous about the drift of terms, and I have to admit I'm obsessed with terms. I did my studies in a field that looked at words and terms. I did my master's dissertation on looking at the drift, the change that was taking place when suddenly the field wasn't health education anymore, it was health promotion. That was the focus of my research study. I did my doctoral research study on this notion of at-risk. You know, that people are being told that they're at risk and they're expected to change behavior. What in the world does that mean? Words are incredibly important. What is a health literacy intervention, for goodness sakes? I'm not sure that there's such a thing. There's health literacy research that focused on links between literacy and health. There are insights to be drawn, but in intervention, we've had health education that talked about participatory modalities, and you know, from the 1920s and probably even before that. Mayhew Derryberry, Dorothy Nicewander, we have all of the things that we talk about have been well articulated in health education and health promotion. We have to ask, what insights can we draw from research, most recently focused on the links between literacy and health, that can inform and improve our designs for intervention work, for dialogue and discussion with the public. We have to expand our notion, I think, and not start a whole new little narrow focus with new names.
Just Scott, and then I'm going to take the chair's prerogative.
All right. I wanted to pull Rima's idea, but pull it in a different way.
Always.
Yeah, but it's the idea of adopting other people's rhetoric so you use them to accomplish your goal. If our numbers are right, and so there's questions about that, but I think they're right in the approximate. The returns on an investment that would fix health literacy, there's $87 billion in additional labor income in the country. There's an additional $3 billion to be saved in income support payments, and only $1 billion in the direct costs of healthcare. So if you just go, if you wanted to accomplish your goal and save your billion in your own system, you could also get a lot more purchase if you start talking about the labor market impacts of ill health and the income support impacts of ill health and low health literacy. It's just a way of making yourself far more attractive to the people who have much more to gain than you.
So I just sort of want to build on a few comments. I think patients are really important. You know, Connie will attest to the fact that the shared care meetings in BC always begin with the patient giving their testimony. Amazing, powerfully, in front of all the physicians, allied health workers. Every meeting there's 4 or 5 patients, and I attest to your statement. They really add to the output because the patients are there and they're saying, well, why don't I have pulmonary rehab in my community? What's going on? So I think they can be powerful motivators and movers of the system. To Rima's point, I'm glad to say that we're in the Vancouver Sun this morning. It's the local newspaper, and yesterday at lunchtime I was interviewed by the UBC, whatever, it's their annual report, and based on work that Iraj and I have previously been sort of publicised within the Faculty of Medicine, they've picked it as one of the key themes to emphasise in the overall university report this year, health literacy. So I think nibbling away, all of those things kind of work. I just finished my comments by saying to Scott, my sense is that $1 billion on the healthcare side is way underestimating. I can just tell you in COPD exacerbations in Canada, it's $1 billion. We've just had a participatory, it may not be health literacy, but we put an intervention together in Vancouver Coastal that's reduced admissions by 25%. And some very interesting data that most of them is not here today on productivity loss around chronic diseases. Huge incremental gains to be made. So I wouldn't underestimate the value add. So I'm just going to stop there and let Connie and then Iraj and then Nisha. I think that, oh sorry, I beg your pardon, I did see Irv's hand before I go ahead.
Oh, just a quick comment about terms, and I just add a little historical information. In 2002, Keith Tones, who was the editor of Health Education Journal in the UK, wrote an editorial about health literacy saying, is this old wine in new bottles? And basically he was arguing that we really don't need this concept of health literacy. It's foolishness. We've already got concepts that deal with the same territory. Personally, I don't think that was a valid argument, but I'd just be interested in knowing whether people here think that Keith Tones had a point.
I'm just going to hold that question, people reflect, because I'm conscious other people wanted to talk about the previous dialogue. So I think Connie, Iraj, and then Nisha, and then people can reflect and answer Irv's question.
Yeah, I'm thinking back to Jim's comment about individuals and groups, and I think as far as interventions go, one of the things that's been quite successful in British Columbia are the chronic disease self-management programs. Now, if you talk to Kate Lorig, she will say, well, that's not a health literacy intervention, but I think as she's thought more and more about it, it incorporates aspects of health literacy, especially the new revision where there is so much more information about dietary information, and there's a whole thing in there about shared decision-making and how you collect information. And so those kinds of things that are group interventions that are delivered by peers in the community are incredibly powerful and very cost effective. And then as a person who raised 3 children, when I think back about what I wish I heard that my kids were learning in their health class at school, I think there's huge potentials for thinking about what that basic preparation of any child is, what they learn in health class. It seems to me like there are some things that could be done that would be incredibly helpful.
Okay, thank you.
In terms of the patient and the individual, based on my own experience, in some of the language and some of the communities, there is no term or word of health literacy. So we basically try to come up with a definition, the components, but we don't try normally to ask people what that means health literacy from their own perspective. I believe we may need to come up with a more universal, understandable, easy to follow the word of health literacy and what's the definition of health. Even we have still problem with the health because health has different definition and different understanding in different culture. So if we are going to basically work in different cultures, we need to make sure the health literacy is something understandable and practical for basically people not just from the Caucasian and also from the other language group.
Thank you, Nisha.
Thanks. I just wanted to say one comment which was about the patients. I think patients are important, but actually I think it depends on what you're trying to do in terms of whether you want the wider community as well. Because I think some of the stuff that I'm thinking of acting on having been here, in terms of getting young people talking about subjects, so you're not actually trying to teach them anything, you're trying to get them to think about what their lives are like for them and then how they can take steps to make their own lives better, and that's not ignoring that there are structural and all the other stuff going on with it, but helping young people think about the responsibilities they have themselves. So I think it's not just about patients, it's thinking about working with schools and also thinking, I think one of the things that I actually think we're going to do a project in schools, I just sent an email to a colleague to say, I think we can do a better project not going into school, because actually we become a wider head if we do it on the internet. So thinking a bit more creatively about how you think very carefully about the question that you're trying to answer before you launch into kind of a random response. And I think sometimes we'd say, you want quick results, so you do something that feels right, but actually sometimes it's better to take the time to think about what it is you're going to do. And I found it incredibly useful, because I think we're going to get a project that's going to actually make at least 1 million kids in Leicestershire think differently about their mental health. They access, not we've got 1 million kids in Leicestershire, that's our population, sorry. And they're just thinking that if we do that, it's just giving that information to people in a different way. I'm sure there's stuff out there already, but it's thinking about what we can provide as healthcare providers that's different to what's on there from a voluntary organisation or whatever. So I found it really useful, and I just wanted to say that there are things I think that will come off this that may not be big, but will still make a difference to somebody in terms of what they understand about mental health. And I think sometimes small is important as well.
Small is beautiful. Now we will return to old wine or new wine in old bottles.
Well, personally, I think that the world is actually a better place because of the concept of health literacy. But I don't know what Keith Tone might think about it today, whether he would accept the view that health literacy has actually developed some very innovative collaboration between different disciplines across countries, within countries, between different kinds of organizations. So it's really kind of set off a chain reaction, and I think that, I mean, not necessarily everything that's come out of it is positive, but I think in general it has made a contribution, and it's increased dialogue, and it's I think made a better life for at least some people in this world.
It's funny, I was actually thinking about that article last night, and nobody ever successfully wrote or replied that. Maybe they wrote it and it just wasn't published. But it's never been addressed in the peer-reviewed literature as an argument. And I have to say, I might be mishearing you, and I hope I am, but when I hear you say there's no such thing as a health literacy intervention, and that the concept shouldn't change, and that health education and health promotion have it all, except for a little tweak that maybe health literacy can provide them, I hear you making his argument. And
no, that's not what I meant to say.
Okay, but to me it sounds like it. It sounds as if it's the same, and I'm not sure then what it is that we're trying to protect. I know what he was trying to protect, which is the status quo disciplinary structure. I don't see anything beyond that. So I have to remember because I said.
I perhaps misspoke and wasn't clear about that. I think what disturbs me is that if we drift away from a central notion of paying attention to literacy or literacies, then we are in danger of simply calling any old health education program or any health promotion program a health literacy program. So I think it's imperative that we really highlight what it is we're doing as an add-on, what it is that's the important insight that we've drawn from research in health literacy that has enriched this program. Because too often I'm hearing in many forums, I'm hearing a description of a health education program, but simply people are changing the name and are calling it a health literacy program. And I think that the rigor of our work really it's very important, because health literacy does offer tremendous insights. But I think we have to highlight that. We have to emphasize that. We have to focus our research on how does this attention to literacies, to dialogue, to the word, to interactions that are based on this communication, how has that enriched what would normally be called a health education program? So I think that we would be missing the boat if we just suddenly drift and take that word to mean everything that we're doing in interventions. I think there's the danger. So I'm sorry that maybe I wasn't clear this time either, but I'm sorry for the lack of clarity.
Irv raised his finger before. Irv did you
Yeah, I just wanted to point out that some of the leaders in this field, like Don Nutbeam, came into this not from the point of view of developing a whole new discipline. He came into it from the point of view of looking at how this concept of health literacy might improve health education, and looking at it as an outcome of health education. And I think the physicians in the States, the primary care physicians who came into the field and developed it in the States, didn't come in it because they wanted to develop a new discipline. They wanted to come into it because they wanted to improve patient care. So health literacy is a bit of the picture. It's not the whole picture. I think it's a great tool for getting people to talk to each other from across disciplines and learn things from one another. But it enriches other fields.
So, I mean, just in reflecting on what I've been hearing, I think one of the interesting things here is the heterogeneity of what we're talking about as health literacy. And actually, it strikes me that they're quite different things that we're talking about, and we're using the same words to describe them. So we've been talking about education in schools. Like, what should we be teaching our kids under a health literacy banner? And we're talking about patients with COPD. And we're talking about power imbalance, like addressing a power imbalance between a physician and a patient. And we're using the same words to describe those. So we've actually got incredible heterogeneity in terms of what we're talking about, and yet we're using the same words to describe it. And I'm actually not sure that that's, for me anyway, as a bit of an outsider, very helpful. Because I think what we mean by health literacy in the context of education in schools, what we're talking about is, kids who, are largely healthy, how do they maintain their health throughout their lives? And that agenda is, for me, quite different to, someone who's got a diagnosis and a chronic disease, and how do we ensure that they maximize their health and are motivated themselves to maximize their health. So I think that heterogeneity doesn't necessarily help us when we're using the same words for those different things.
And Nancy?
Let me take a crack at it. So a lot of, in terms of taking care of your health, a lot of it is left up to the patient. So, I mean, you need to be able to read, you need to be able to use numerical information, you need to have search terms now on the internet, you need to be able to sort of take information and sort of work with it to make sure you can understand how it applies to you. And so when you talk about children in school, you're talking about sort of giving them the skills that they need before they have a chronic disease, before they're in a crisis situation, to understand how to do different tasks. So I think it does all fit. It's not heterogeneous. It's coming at a problem from a variety of different perspectives or trying to head off a problem.
And I guess just to add to that, it's interesting you mentioned COPD and health, but the best thing to do would be to educate children not to smoke. So there are some overlapping vectors. Well, maybe that's not the single most important thing, Nisha. Marie?
But I think that if we go down that way, we're still missing that other piece. Because if we only think about health literacy lens as looking at the individuals, either in schools, either in at work or whatever, missing the other piece that, at least in my new insight, it's not complete when we are defining or thinking about health literacy, which is those other pieces. Because you can have people who decide not to smoke, but they might have an inherited thing. And then they face the system again, and if the system is still coming against them, it's not all about what the, and I don't mean not to empower people with knowledge. I'm an educator, so I'm fine. But when we're talking about health literacy, I like to really push to thinking about the different components that have to be thought about when we're thinking about health literacy, and it's that system and providers perspective.
I think that the missing element, the only tractable way to draw everything together is to talk about tasks. So society or the institution or the practitioner creates a demand for someone to do a task, and the question is whether they have the skills to respond to that task. Because then you can talk about both sides of the equation in the same breath. You can use it to measure, and you can use it to adjust practice on both sides. So give people higher levels of skills and adjust the demand level. But so in the work that we've done, task-wise, if you look, there's a bunch of tasks that are managed orally, and so the question is, do people have the oral fluency to deal with those tasks? Then there's a set of tasks, the health literacy tasks we have include prose literacy, document literacy, numeracy, and scientific literacy. And the fact of the matter is that the weights of those things changes as the health literacy task becomes more difficult. So documents are more important in the middle and numeracy is more important at the top. So you can't just say it's health literacy, it's health literacy with a set of implicit demands in it.
I think this is a really interesting conversation and debate, because I think it's reflecting a fundamental debate that goes on inside the field of literacy itself about what constitutes literacy. And is literacy simply about information and discrete skills, or is literacy about all these things played out in particular contexts and in the world and through interactions in social settings? And there are two very strong strands, right, of literature in the field that argue constantly about this and debate it. But I think that's what's getting reflected here. You're seeing, is literacy just about a set of disembodied skills or tasks that you look at in isolation? Or is it about how these things play out through community action, through social interventions, through the context in which people actually live and work? So it's the word in the world.
Victoria, go ahead.
Yeah. Thank you. Yeah, so definitely I'm glad that just the focus on the term literacy or the construct of literacy, I was going to present on that tomorrow, but I'm going to stop on my 2 minutes in here. Absolutely true that some people still think, you can tell by the way I present this, which side I'm on, but some people still believe that literacy is somehow learning how to read disembodied text, and it's disembodied from a social context. I tend not to think that that kind of reading is disembodied from a social context. I believe that all literacy is embedded in social activity. I was challenging some people last night at dinner to give me one instance of when you read or write something that is not embedded in a social activity. And each of those different social domains bring with them different demands, different purposes, and different uses of those skills. So whenever I hear us talk about, let me see, just literacy, for example, is it just literacy or is it health literacy? Is it regular literacy or is it health literacy? You know, that kind of thing. That's where it gets very hard to deal with if you're coming at it from a literacy perspective like mine that sees there is no just literacy. I think that means basic skills that are embedded in a schooling context, which is learning to read and write, which is a very necessary thing to do. But you don't do that kind of reading unless you're in school, learning to read and write. So you have very different purposes and use of skills and so on. So I think that, I don't know where it's going to, but anyway, when you're talking about, for example, a health literacy intervention, you know, I keep trying, because I'm coming at this from a literacy perspective, that sees health literacy as simply a type of literacy. It's not literacy plus health, it's a type of literacy. Financial literacy, which is also equally important, especially in this day and age, is a type of literacy. And we all are very highly literate people, but I think I have higher health literacy than I do financial literacy. And perhaps financial literacy is just as critical to my well-being, it is right now, as the health literacy. So it's not this sort of joining literacy with health. It's thinking of literacy as meaning making. It's a language process. This notion of who do we focus on, the provider or the patient, from a literacy perspective, Do you focus on only the person reading, or do you focus also on what they're reading and who wrote it? And from a language perspective and communication, it doesn't make any sense. You focus on the transaction between those two. So to even think you could divide that up means you've lost your construct. So anyway, that's...
Thanks, John.
I hope that I'm building on that a bit, because I keep trying to learn from Victoria, who gives me more and more insight about literacy and literacies and therefore health literacy. But I want to just give an example of the challenge that's before us in a way of sort of focusing our attention. So I'm going to actually, I want to talk about inquiry, measurement of consequences, and then the challenge that lies ahead for us as health folks who really want to make a difference. So it's a piece of research that I did with Laurie Martin, and Laurie took the lead on it, so if I misstate anything, Laurie, you'll make a correction. We developed a scenario. What would Joe do? And we had, we did interviews with 600 and something individuals, and they were presented with this scenario. And Joe was presented with a challenge in a healthcare setting, and he had some options, and it really had to do with advocacy and self-advocacy. And there were different outcomes that we measured, but we also had measured a grouping of literacy skills in a kind of abstract that you wouldn't like, Victoria, I know. But still, we were looking at speaking skills and use of vocabulary, looking at reading skills, so we had all of these measures. And it turns out that literacy, if we separated the group out into high and low, literacy made a difference. Because those people who had measured high literacy skills were more apt to advocate for themselves in a productive way. Whereas those people who had lower literacy skills were very often in a situation of frustration and anger and had negative consequences. They didn't serve themselves well or productively by getting what they wanted. So here was an inquiry that was focused on a link between literacy and a particular outcome. This outcome had to do with advocacy. Now we have a finding, and the challenge that lies before us is what is it that we can do in health settings that would help and aid someone like Joe, who might have literacy-related deficits, be an advocate for himself and have agency. So it's an interesting challenge which can help shape an intervention. So here's an example of how a literacy inquiry leads to health consequences, then leads and focuses us on a challenge that lies ahead of us to make a difference in a setting that we have to take responsibility for to some extent. Certainly, perhaps suggesting that Joe go to that great program down the street will help Joe as an individual, but the changes that we make in our institution will help many individuals like Joe have agency, have a voice, be able to participate in decision making in a more active way. But we haven't gotten there yet because we were too busy measuring Joe. That was step one. We have to take step 3, which is make that change and study whether or not that little tweak we're giving to the system is going to help out or not. What's the gold standard that can be the outcome of that? So exciting work lies ahead of us, but it has to be focused. So in that sense, I want to counter and say that there is some specificity that we can have in this arena. And the research eye has to be a focused and specific eye, and then we can really make magnificent progress based on insights that can be garnered from this field.
Andrew, we're getting towards the end of our time.
Just a real quick, I think the problem that we're facing, and actually I think surprisingly enough the three of us completely agree on this, it's about the methodology. So you're absolutely right. All literacy is in a social context. The assessment tools that created the evidence base for health literacy, however, and unfortunately do not take that perspective. They're not based on that. For example, I asked Scott yesterday, will your assessment tool capture the ability, the preparedness of a mother of 2 teenage daughters to actually talk with them before she makes a radical shift in the household food behaviors? Will it capture that? And you said no. And neither would the existing health literacy measures that we have. So when people ask for a new measure of health literacy, it's based on a large part of that, to actually capture what you mean by the social groundedness and relevance of literacies, but in health literacy from a measurement perspective, that's not been done.
That's right. I totally agree. And in fact, those measures that are used in health literacy that were developed a while ago aren't even good literacy measures or even valid reading measures. So, you know, as far as I'm concerned, you can just close that door and try something else. We have been, in my project, working for a long time on developing socially situated assessments that can be used reliably and with a valid construct behind it and theory that we can measure change. And we have found it is very, very labor intensive, and at the academic level means it's very expensive to do, but it can be done. So I agree.
So that's a good way to conclude. We've really enjoyed my own personally this discussion. It seems on reflection to indicate that none of us have the right answer, if that was the thread. And I think all of us need to work together with our various perspectives, biases and personal experiences. But I think it's been a very, very powerful discussion, I think, to bring some unity and clarity and focus. So I want to thank the discussants and the broader panel and for your very helpful contribution. So we've got about 15 minutes now. Are we going to adjourn? Do we need, this is a very nice room as opposed to, are we going to be in theater style next door, or are we going to be? No, I just wonder, are we going to get many more people that we need the other room? Okay, so we go with, yeah. Anyway, it's a nice room to have the discourse in, but we'll see what the numbers are.
Can we send someone out for the newspaper articles? Yeah.
Oh, it's on YouTube already.
Yeah, it's online. It's actually Vancouver Sun, it's online.
Okay.
There's the Dateline.